What I thought I would do today is really take just a few minutes and cover 3 different segments on what's going on in the coding world. One of the first things that I want to talk about is something that we may be using today in dentistry, or some people already are, and more will become involved in it very shortly. And that is diagnostic codes, particularly when we're filing medical claims. The diagnostic coding system that we need to use is ICD-9. So when we're filing medical claims or claims under a medical plan, which are sometimes claims that we need to file for oral surgery or TMJ, myofascial pain things, because they're mandated for coverage in Minnesota, we need to use ICD-9, and sometimes we even have to use the physician's equivalent to this CDT system, which is CPT. Sometimes those result in claims being rejected because we haven't filled them out correctly, and a lot of our claim systems really don't allow us to fill in that stuff. Only recently have we been able to fill in a diagnostic code on our dental claim forms. That began, I believe, in January 1 of 2012. So the capability is now there, but that's fairly new to all of us. The second thing I want to mention on the ICD is that we are beginning to see, because of the interaction, or we're seeing much more of the connection between oral health and overall disease, that several of the medical plans, actually a growing percentage of them, are beginning to look at this and say, in certain cases, we should cover additional dental preventive care, primarily where there's periodontal disease present, but sometimes not even periodontal disease present, such as in the case of a pregnancy. Sometimes they will authorize an additional cleaning during a person's pregnancy. Diabetes is probably the most common one, however, because it's pretty well established that proper oral hygiene can reduce the variation in sugar levels. So those things are beginning to be covered more frequently by medical plans, but in so doing, quite often it is still covered under the dental plan. However, in order for them to recognize and cover that additional procedure, let's say we're going to do 3 of them in a year instead of 2 D1110s or something, then we need to include a diagnostic code on our claim forms again. Again, there's a place for it, and there's a pointer that allows us to point to the specific line on the claim form of what we're asking them to benefit in addition. This is still a little complex in understanding where and which employers have it, but quite often the people that are coming in, your patients that are coming in, will know that. So that's another area that is changing pretty rapidly. The only thing I would caution you on is to make sure that the patient has signed the medical history, because if you put in a medical diagnostic term into the record, I would encourage you to have the ability to go back and document that someone has told you that. And finally, I just want to mention that in October 2014, we changed to a much more comprehensive coding system called ICD-10. And I'm going to give you a website. It's called ICD10data.com. And that website can help you sort through ICD codes, and it'll do it for both ICD-9 and ICD-10. If you just type in the word periodontal disease or something like that, it will give you a list of codes to use in very specific cases. And that you might find that fairly beneficial if you're filing any claims under using ICD-9.
One of the things, Mark, I'm sorry, I just want to jump in real quick. When you were talking about ICD-10, it struck me that when we talk about the need for EHRs, obviously ICD-10 and all the people in the medical world knows those are thousands and thousands of codes. So therefore, without electronic technology, it would be virtually impossible to support the new coding schemes coming up, correct? Like ICD-10.
Yeah, absolutely. We're going with ICD-9. There were something like 13,000 different terms or codes. With ICD-10, we're going to 70,000, and ICD-11 is going to be even bigger than that. So the need for electronic support is great. Now, obviously, those aren't all dental codes. There's dental codes is a small subset of that, but even at several hundred, it gets to be pretty complex. So the need for it is there, Mike.
Thanks.
So the next thing I was going to cover was just some things that are also happening in dentistry that I think are pretty important to recognize, because they're also leading towards the need for electronic health records, or a desire perhaps to have them. One is the risk assessments. Risk assessments are getting to be far more frequent and more frequently requested. This is going to be driven a little bit by public health agencies, but also by third parties. Third parties really want to know if a person has a low, medium, or high risk for caries, because they want to be able to look at it and say, if this person is high risk, do we need to provide additional fluoride treatments or not? Now, certainly there's some concern that they may then adjust benefit packages based on that, but that's a long way down the road. Right now, I think the only thing they would do is enhance benefits to try to reduce costs rather than the other way around, and I really believe that in the market, that would be what would take place. But again, caries risk assessments are already in Snowdent, but in Snowdent they're considered what's called findings or observables. Snowdent has a very deep set of different concepts, and those are two of the concepts that Snowdent uses. In 2014, CDT will actually have those three levels of low, medium, and high risk. And you'll be looking at the ADA's format for determining low, medium, and high on those in terms of filing for informational purposes, mostly at this point. That won't be a service that you're providing. It's actually you're providing a rating. It's probably better for your record keeping at this point than it is for actually looking at claims filing. However, I do expect to see that being asked more frequently from third parties, and particularly I think in the public programs we'll see that first. The second thing that's developing pretty rapidly that I think will be a large help to everyone in terms of being able to identify what problems people might be having is severity indices. And I'm going to give you an example of a caries severity index here in just a moment. Many different organizations are doing, Federation Dentaire International, ICD, and SNOMED CT all have terms that relate to severity, and they're trying to coalesce around a single one so it's easier to do so. But there's a hierarchy that's involved. You always look first if it's a primary or secondary caries, whether it's around an old restoration or if it's a new decay totally. Then the location, and really the location breakdown is going to be either coronal or cervical, and then the severity itself. And that severity, this is just an example of FDI severity index. We're looking at within the dentistry SIG for IHTSDO of looking at a very similar methodology. We already have a lot of terms, but it's not as well organized as this at this point. But you can identify how the severity is. And again, if you had a patient in 3-4 years after you had done a restoration and you knew that it was a 5 rather than a 1 or a 2, you'd have a pretty good idea of why that person might have sensitivity or what type of further treatment you might have to provide before you do anything else. It allows you to treatment plan better. It allows you to provide better predictive terminology and information to patients. So that's where a lot of the severity indices are going, and these are being used internationally at this point, particularly in several of the European countries. And the last thing I'd like to cover is the importance of terminologies to interoperability. As most of you know, Minnesota has a mandate that takes effect January 1, 2015 that requires the use of a electronic health record, and certified or qualified interoperable electronic health record. The only way we can reach interoperability is through terminologies that allow systems to communicate with each other. And the terminologies are normally hidden behind the screens that you're using. You'll never have to know these terms necessarily. You'll just have to know that they're there and working that way. And the ADA has developed a fairly comprehensive one for dentistry called Snowdent. It's still being changed and modified and added to on a regular basis. It's part of SNOMED CT, and because it's part of SNOMED CT, it's not only used internationally. I think there's 23 countries that are using it, but it's also a HIPAA standard for meaningful use. So if you're filing for meaningful use incentives, the system has to be able to classify it in SNOMED CT terminology. And finally, it allows the EHRs to really develop a different system. A lot of the medical EHRs use screens that allow the physicians or nurses or PAs or whoever to put in information, findings about a patient. It might say blood pressure is high, low. It might ask for any number of different characteristics the patient has, and you'll hit little radio buttons to do so. And as you do so, the machine is collating all this information, and then it'll come back after you've filled all it in and say, is this where you want to go with this? Is this a possible diagnosis? And you pick from a list of diagnostics. It's called a decision support system. They're commonly developed in medical methodology, and it's the way medicine has always worked, or at least the last 25 years, medicine has looked first at the diagnosis and then at the treatment. Dentistry is just beginning to enter that era, and it's probably going to be necessary to follow along that path with by using an electronic health record.
Well, and Omar,
that's what I wanted to say.
Well, what I was going to say, I'm really glad you brought up especially the last one, because even if somebody says, well, I don't care about the mandate, but they say I don't care about meaningful use, the last point that you're bringing up is so important, because having been through myself for over 12 years with the evolution of EHRs in the medical world, it's gotten very sophisticated in terms of what you're talking about, clinical decision support and evidence-based treatments using diagnosis codes automatically. So I think as it gets more sophisticated with coding, we're going to see a lot more decision support type of mechanisms built into software. And I think that's going to be really important. The other thing too, I'm glad you pointed out the HIPAA standard being SNODEN, because I do get a lot, and I'm sure you get a lot of people in the industry, in the dental industry, that say, well, you know, I'm not sure there could be 10 coding systems, and I'm not sure where this is going to go. But maybe you can comment real quickly, but it seems like SNODEN, just like SNOMED in medicine, SNODEN will be the emerging standard for a lot of us, correct?
Well, I think right now it's the only approved HIPAA standard system for meaningful use, and it's looking also to be used for claim submission, so that you could actually start using it as the disorder or diagnostic coding system also. SNODEN will probably, or SNOMED CT will probably include all of the different terminology systems that are in existence today in dentistry. It's a broad system, and so it will be inclusive of all of those systems, so that various different EHRs may choose to use a subset that may be more specific to orthodontics or periodontics or something else. So we may see something like that. There's a developing terminology within the schools called easy codes, and they may choose to stick with it once all of the terms are within SNOMED CT. So I think we will see various things like that, but if anything, they're all going to be subsets of SNODENT or SNOMED. The only other point that I want to make, that I just want to emphasize here, is that even though there's a mandate and there aren't any penalties, understand that it's a state law, and it's going to be very difficult for our Board of Dentistry to look beyond the fact that it's a state law. So I think it's going to be necessary for you to move in this direction regardless of whether you want to or not. It's kind of the next step, but there's also a tremendous number of competitive reasons to do so. The systems are going there very rapidly. The marketplace is looking at this rapidly. I think you would find them to be very, very beneficial, not just because you have to use it, but because they're good for you and your patients.